Good morning, everybody. Thank you very much for joining us this morning for our second in the series of 4 webinars dealing with psychosis intervention. My name is Jenny Allen. I'm from WICHE and the mental health program, and I am delighted to be able to bring this to you today along with Ari Garcia from the Wyoming Department of Health and uh, Tamara Sale, and Ryan from ESA. Ari, would you like to introduce yourself?
Sure. Hello, this is Ari Garcia with the Wyoming Department of Health. I'm just excited to be starting the second webinar. And so the 5% set aside is a portion of our mental health block grant that we are going to be using to um, give to a provider or award a mini grant to a provider who applies through the treatment application process for the treatment of first episode early psychosis. So we're excited about this, and I will just pass it over to Tamara, or Ryan.
Okay, yeah, thank you for joining us all. My name is Ryan Milton. I'm the Clinical Training Director for the ESA Center for Excellence, and today we'll be talking about kind of the development of psychosis and some of the delays in individuals seeking and getting help. Tamara?
Hi everybody, I'm online today as well, and I'm going to basically be playing a supportive role, so I might throw in a story or two or answer a question, but just letting you know that I'm here, and we're so glad that you joined us today.
So the the WICHE Mental Health Program has a twofold mission. We assist states in improving systems of care for mental health consumers and their families, and to advance the preparation of a qualified mental health workforce in the West. This particular series of webinars is a perfect example of our mission, because we're able to collaborate with one of our institutions, which is the Portland State University, and also the Wyoming Department of Health, who is one of our member states. And this collaboration is one of the WICHE overall premises to collaborate and share our expertise with each other to enable our improving this workforce. So I am really thrilled to be able to work with both the Wyoming Department of Health and ESA to bring this series to you.
All right, so today's discussion will be talking about how psychosis develops, with an emphasis on what it looks like in the earliest possible stages, with the goal, of course, to identify psychosis early and, of course, engage in treatment. So we'll talk about those early signs and symptoms, and then ways to get help. We'll talk a little bit about why there's such a delay in receiving services in the U.S., and why that delay is sometimes between 1 to 2 years. And then we'll discuss what you, families, community providers, and others can do to help reduce those delays and hopefully successfully engage people in care. Just a reminder of the next 2 parts of the series. So next week we'll get into some of the best practices, so we'll get really more specific into some of the treatment practices used in early psychosis programs, and talk about some of the resources that are available, and then end on the 25th around creating a system that works for people with psychosis. So getting specific to what you can do as a system to set that up, with the emphasis on setting up systems like this in rural communities. So more of a discussion on that week. I've talked about this before in previous webinars, but there's maybe a few new members on the line today. I want just to remind us of the symptoms of acute psychosis. Let me define acute psychosis. Acute psychosis, at least defined by the DSM, is when individuals not only they'll experience symptoms of psychosis such as hallucinations, delusions, disorganized symptoms, but they'll experience it at a level where the individual struggles with the ability to tell what is real and what is not real, and oftentimes will act on those behaviors. I'm making that distinction in defining acute psychosis because that's going to lead into a lot of our talk today. I will be talking about attenuated psychosis and subclinical psychosis and how that potentially looks different, and how the engagement and treatment may ultimately look different. Just to give you some background, you probably, everybody on this line is probably familiar with this, but again, acute psychosis is oftentimes defined by hallucinations, delusions. We refer to those as, and disorganized communication, we refer to those as positive symptoms. And here are some examples of positive symptoms, whether it be kind of unusual thinking, which we might refer to as delusions, belief that people are reading one's mind, belief that there's signs in the community that are speaking directly to the individuals, paranoia to the point that someone may be hiding in a room or avoiding specific individuals when that in fact may not be true with reality. And obviously perceptual disturbances, which are more in the forms of hallucinations, seeing, hearing things that other people don't see or hear, and then disorganized communication. Also want to just touch briefly on negative symptoms. So these obviously are symptoms that basically shouldn't be present, or symptoms that are at a loss. Obviously I don't mean bad symptoms. I just mean symptoms are behaviors that should be there that are no longer there. So the person may not be as social, may not feel as motivated, may have difficulty in identifying and expressing emotions or enjoying things that they used to enjoy. You might also see impoverished speech or thinking, and a decrease in your normal range of intensity and emotions. And usually these type of symptoms are accompanied with frustration, sometimes accompanied by affective changes like feelings of sadness, but not always. And that's one of the distinctions between negative symptoms and depression, since they can look quite similar. As psychosis develops, one thing that we generally know from the research is that it's the negative symptoms that occur prior to the onset of the positive symptoms, and then it's the negative symptoms or the symptoms that individuals complain most about in terms of causing disability and functional challenges. And these symptoms obviously are not as easy to identify as the positive symptoms. Unfortunately, they're the ones that come first and are the most disabling. So we want to get better at that. It is good as that is then identifying these symptoms as well. Excuse me. Okay, so let's talk a little bit about those delays in treatment. Most of the research supports that there's a critical window of 3 to 5 years. What does that mean? Is that within 3 to 5 years of the onset of psychosis is the most critical period in reaching out and providing someone with treatment. It's the window in which high levels of disability occurs. It's the window in which most functioning is lost. It's the window in which suicide is at the greatest risk. Some recent 10-year results say we have a window of only 2 months post first acute psychosis to really engage people in functional skills such as work, school. And if we don't do that early enough, that identity may be lost and they may not engage in those at all. The average duration of untreated psychosis, so that is duration of untreated psychosis is defined as the moment in which somebody becomes psychotic. So when I say psychotic, I mean acute psychosis, to the point in which they receive treatment. Treatment sometimes is defined differently in the research, sometimes defined as the moment that somebody takes medication, and in some studies defined as when they enroll in a treatment program. Why is this DUP important? We talked about the critical window, but also delays are associated with more severe symptoms. Sometimes as the longer the DUP, the more severe the symptoms, the harder it could potentially be to engage somebody. Decreased rates of remission of symptoms, and decreased social functioning and quality of life. And it's the decreased social functioning and quality of life that I think early psychosis programs are most concerned with, because sometimes that is hard to get back. Okay, so let's kind of talk about the stages in which individuals will assess care and those opportunities then that we have to reduce delay. So it's obviously we'll start with recognition. Recognition is an interesting concept in the fact that it may or may not occur by the individual. Sometimes in the early possible stages, the individual may be experiencing some symptoms, but as those symptoms actually get worse, the recognition may ultimately be lost. And that's when we lean heavily on families and support systems to kind of recognize the symptoms. So early on, recognition, so it's kind of contradictory in some ways that early on the symptoms are more likely to be recognized by the individual experiencing them. A little bit later, the symptoms are more likely to be recognized by the families, social support networks, and the community, which then speaks to our opportunity to ways to reduce these, reduce DUP or help access care is to provide high levels of community education with symptoms occurring as early as possible. So both individuals, when they are at a point they can recognize symptoms, will seek help, as well as families start recognizing earlier symptoms and seek help. I'm currently working on a duration of untreated psychosis study with the ESA Center for Excellence. We're finding some pretty interesting things on recognition and help seeking. One thing we're finding is that recognition tends to be, hallucinations actually will predict higher levels of recognition and help seeking than delusions, which in some ways makes a lot of sense, knowing that delusions are defined as a lack of belief of something that is in reality. So why would someone actually seek help when they're delusional, when they believe what they're experiencing is real? And that's when the family and support networks need to, are more likely, to step in. And so this point between recognition and help seeking certainly can vary in duration. Can be a very short amount of period, depending actually on sometimes on the symptomology. It's like low levels of subclinical symptoms may take a long time in which someone actually seeks help. More acute symptoms like acute delusions will be picked up by a family or a support network, and that will engage potentially in help seeking. The key in all this, however, is the agency response and the early psychosis program response. We in these particular programs, because we're working with individuals who are now experiencing acute psychosis, we need to respond in a way that might be different than traditional communities have responded. For example, many of our families report calling an agency multiple times trying to get help, only to be told that, well, we can't really do anything unless the individual is willing to come in, or if they're dangerous to themselves or others, then we can call the police and meet them at the emergency room or send out a crisis response team or something like that. So we kind of have two opportunities. One, if an agency can respond in a very early stage, we can engage somebody when they're able to talk about their symptoms, or we end up engaging in a stage where the symptoms are acute, and we have to be a little bit more flexible in our responses that way, which might mean working directly with the individuals who are help seeking at that stage, which is oftentimes the family and the support network. Sorry, just checking out the next slide. There's a few predictors of delays that I want to talk about. Some of those delays have to do in the help-seeking process, whether it be the individual or the family, is this lack of awareness of resources. Again, that's where community education is going to come in. There are certainly racial differences in DUP and ability to seek help. African Americans, for example, have a shorter DUP, which actually might be a result of stigma and stereotypes in which symptoms are pathologized sooner in African Americans than they are in Caucasian Americans. Another unfortunate predictor of duration of untreated psychosis is enrollment in a mental health system. And so that could be twofold on why that occurs. In potentially early stages of psychosis, clinicians aren't trained to recognize it, and it gets labeled something like attention deficit hyperactivity disorder, or or, or another depression or another condition. Whereas somebody who's ultimately at an acute stage of psychosis and delusional may be picked up by an agency, say from a hospital, but because the agency isn't able to engage in a careful way, in a way that meets their needs, they ultimately drop out of the system, again resulting in a longer duration of untreated psychosis. So the duration of untreated psychosis can exist in both the early stages of psychosis and the late stages of psychosis. Again, I hope you're kind of understanding. It's how we respond based on the stage. All right, so I can talk about some of these. So again, where our opportunities are education about the specific changes to watch for in psychosis. And again, obviously, the earlier that we can catch the symptoms, the better, because that's when the individual themselves is more likely to engage in services, because their symptoms are ego-dystonic, they're causing some problems. Once the symptoms go too far, the individual may not recognize those symptoms and unlikely to come in. However, when you're identifying individuals in that earlier stage, it's important to focus on normalizing what they're experiencing as a common condition with a likely positive outcome, and also to be very careful with premature labeling. We at ESA in Oregon use very specific tools which help us identify whether someone's in an acute stage of psychosis, where we might give them a diagnostic label of schizophrenia or other schizophrenia-related disorders, versus in a subclinical stage, which we would then refer to a psychosis risk syndrome, or potentially another diagnosis, without using that label of schizophrenia. The reason for that, obviously, is schizophrenia is a stigmatizing label, I think, which we're all aware. Plus, at that early stage, it's actually an inaccurate label, because we don't know if individuals in this early stage of psychosis are actually going to go on to develop schizophrenia. Yeah, some of these things I have talked about in terms of help seeking. And obviously, one is just knowing where to go, and that's on us as early psychosis programs, in terms of us providing education in the community so people know actually where to go, and referrals knowing who to call, and that connection happens as rapidly as possible. Also, trust in a provider agency, that the agency will respond in a way and not just say, sorry, call us back when the individual is really dangerous. And then obviously it's on us to overcome our own stigmas and have a belief in a positive outcome. So in short, developing positive community relationships, being visible. We want people in Oregon to recognize that little compass that you see in the right-hand corner as ESA, in the same way that swoosh is recognized as Nike. So we put a lot of time into our own marketing. I recognize it would be a stretch to think that ESA is going to be as famous as Nike, but we keep our goals high. Then obviously rapid access, that we do not wait. It sometimes might not take long before someone moves from a subclinical state to an acute state, and then the engagement changes, how you approach the individual changes, and obviously the later, the more difficult it is to engage the individual in services. Obviously focusing on positive language and providing hope by giving positive examples. Yeah, in terms of how, one thing we obviously want to do as agencies running early psychosis programs is to have a rapid response, but having a system in place that prioritizes these particular individuals for care to move quickly. An example of that is that we encourage, and in most of our programs in Oregon, all of our licensed medical professionals, our doctors, our nurse practitioners, hold a slot in their schedule each week that is set aside for ESA clients, whether that be a new referral to ESA early psychosis program, or for someone who is in crisis. Obviously, insurance, we're probably all very aware that that's a barrier, can be a barrier to treatment, so early psychosis programs are asked to accept people regardless of their payer source. If we're going to do prevention work, we can't put in place some type of barrier like insurance. Historically, before the Affordable Care Act, 2/3 of the individuals in Oregon were either uninsured or on private insurance, which actually made access to early psychosis programs difficult. So we had to help kind of supplement um, those individuals. Obviously, things that need to be modified as requirements around entry into the program, like for example, telling somebody who's acutely psychotic that they need to accept their condition and be motivated and able to come into the office and meet with a prescriber, meet with a counselor, and start work immediately isn't going to happen. We have to change those rules. We have to actually accommodate for the illness. Remember, the definition of true psychosis is that the individual stops the ability or lacks the ability to tell what's real and what's not. So their delusional belief system is very real to them, so they're unlikely to seek help for something that feels very real, at least not around the symptoms themselves. They may seek help around the stress of the symptoms or how bothersome the symptoms are, but they may not seek help for the symptoms themselves. I hope that makes sense. Obviously, you have to work directly with the family, especially in this acute stage, because the individual who's experienced the symptoms of psychosis may not be willing to talk to you. Be careful of diagnostic language, particularly in a very early stage of psychosis, but also in a later stage. Again, telling somebody who's acutely psychotic that they have a medical condition called schizophrenia and what they're believing is something called a delusion, you're likely to get some pushback on that and ultimately could lose them. And then be careful, obviously, of pathologizing, telling them again that they have a mental illness. Just read a recent article that described using the term mental illness to individuals actually increases disengagement from systems. So obviously, I think that makes sense. The term itself is quite pathologizing. And obviously sending a message of hope. I've unfortunately listened to many mental health providers tell individuals in very early stages that they have schizophrenia and they're going to need to take medicines probably for the rest of their lives, and here's your application for disability. And the truth is we just can't predict what somebody may or may not need long term. Again, watch someone very acutely psychotic be told that, and then within 4 weeks actually was quite cleared up actually without medicines. Maybe it was a brief psychotic episode. Don't know what happened diagnostically. But that, of course, was not the outcome for him. And then follow through and outreach, staying in touch with families, particularly in acute stages, offer them support, resources, crisis planning, triage planning, whatever you need to do. So again, not waiting for the individual to come to you, not waiting for the individual to reach a crisis point, but either trying to prevent that or at least support the family and helping the individual get help. So again, our opportunities to impact, changing policies and procedures that allow us to be more flexible in being proactive. So letting your front desk know that if they get a call from your early psychosis program that they may not have to go through the normal intake process or orientation process if you had something like that, but it goes directly to the early psychosis worker who's trained in specific languages, how to do outreach, and kind of the policies and practices around early psychosis. Okay. There's a lot on kind of what we can do. Now let's kind of talk about what it all looks like and kind of what are some of the causes of psychosis. Now, why is this slide important, and why am I talking about this? Because one area that I think is a big strength of early psychosis programs is differential diagnosis. We're trained to understand that psychosis is a common condition, or is a common set of symptoms, And schizophrenia, however, is a very rare condition, meaning that the symptoms that we refer to as psychosis can occur in a wide range of conditions. And certainly the last thing we want to do, or one of the last things we want to do, is to label someone as having a major psychotic disorder when in fact it's a medical condition or a depression, anxiety disorder, post-traumatic stress disorder, or something along those lines. So it's important as you're meeting with people early on that there's going to be some diagnostic ambiguity, that we don't always know what's happening, and part of our job is to try to figure that out. I have this slide up here to kind of talk about some of the common mental health conditions or mental health symptoms that we see from individuals who seek help or that are being served in our agencies. To kind of help with differential diagnosis, I've drawn a series of lines. Kind of your direct lines or your straight lines are symptoms that are either directly psychotic disorders or have a psychotic element as part of them. Or obviously schizophrenia, we know schizophrenia is a psychotic disorder. Mania, bipolar disorder, bipolar 1 with mania and psychotic features. So obviously somebody who is manic, there can be a psychotic element as part of that. Medical illnesses certainly can cause psychotic symptoms, and we know that illicit drugs and actually in some cases legal drugs can cause psychotic disorders, and the drugs is one of the largest in terms of its font. That was purposeful because that is the most common cause for psychotic conditions. So try to give a visual diagram of direct causes of psychosis or psychotic illnesses. Made the font at a size that kind of shows how prevalent psychosis is with those particular conditions. Other conditions or symptoms like trauma-based disorders, PTSD, stress, depression, all can have psychosis as its element. It's not quite as clear if it's true psychosis or if it's more psychotic-like symptoms. And then there's other disorders like attention deficit hyperactivity disorder, factitious disorder, malingering personality disorders, oppositional defiant disorders, in which the behaviors associated with those conditions can look quite psychotic, but in fact are not. And that's really our job, one part of our job is to help differentiate that. So why is this so important? One, misdiagnosis is common. I think sometimes, and we have a hammer in our hand and we look for nails. We're an early psychosis program and we're going to look for schizophrenia. So we ourselves can be guilty of overdiagnosing those conditions based on our need or our desire to be helpful. So again, we want one training that we really like early psychosis programs to have is to have very good training on differential diagnosis, knowing the quality, content, frequency of symptoms and how they relate to conditions like schizophrenia, depression, anxiety, post-traumatic stress disorder, autism spectrum disorders, etc. Again, it's also important because different conditions can cause for different treatment. We know that individuals who have a schizophrenia psychosis are more likely to respond to atypical antipsychotics, the medications, than somebody who has more of an affective or major depressive disorder with psychosis or psychotic-like experiences. One tool that we use in ESA is a tool called the SIFS, the Structure Interview for Psychosis Risk Syndromes. That's a tool which we use to determine eligibility into ESA. If the individual scores in one of the psychosis risk ranges on this tool, we will accept them into the program. But we also know the tool has its limitations in that people can score on the tool who experience psychotic-like symptoms to anxieties. So it's important that the clinician who's administering the tool has training to understand what symptoms of anxiety might look like versus true psychotic symptoms related to a condition like schizophrenia. I kind of put this in here to just remind us the steps in differential diagnosis and kind of what they are. Obviously, the first step is you want to rule out any environmental, cultural, or behavioral explanations of the behavior. So we don't necessarily go directly to the mental illness when somebody's behaving in an unusual way. There may be a very good cultural, environmental, or behavioral reason why they're behaving in a way that's different than what we'd expect. Second is we have to rule out any substance etiology, so that would be illicit and legal substances. DSM-5 has really stressed this more than DSM-4 in terms of really focusing on ruling out the impact of substances on individuals in terms of creating symptoms. Obviously, we should also rule out any primary medical condition and head injury. In ESA, we ask that as part of the assessment, everybody get a series of medical tests to rule out any underlying medical causes. With young people, this will be rare, but you don't want to miss it. And unfortunately, we've had a couple of circumstances in ESA where we thought somebody had a major psychotic disorder, and it turns out that there was an underlying medical condition. Then you determine the primary disorder. So you determine that based on the symptom presentation. Then you determine if those symptoms meet frequency and severity level and that are not adjustment. So again, within the DSM categories, there's severity levels, frequency levels. We have to make sure that those are met. This is one of the more common misdiagnoses that I will see with particularly disorders like bipolar disorder and ADHD, where they'll have some lower level symptoms of the primary disorder, but they don't meet the frequency and severity level to be called something like ADHD or bipolar disorder. So you really have to establish that those frequency and severities are met. Then you establish that the definition of a mental disorder is met. The definition of a mental disorder, in short, is that it's something with an underlying biological, physiological, psychological cause that is not due to a cultural reason and that is causing significant levels of distress. So somebody who is seeing or having a visual hallucination of a loved one who recently passed that comes and visits them only at night, that the individual actually finds helpful to engage in a conversation with, that doesn't cause any problems, meaning they're still able to go to school, go to work, no relationships problems, we wouldn't refer to that as a mental disorder, even though there is a psychotic-like experience associated with the individual's behavior. Then finally, if we do find that the individual should receive a SIPS assessment, we complete that. And that is a reminder that the psychosis with syndrome, although the SIPS defines that, that's not a clear psychotic condition in DSM-5, so we got to be careful on the labeling of that. Quickly, some of the differential qualities of psychotic disorders. So when I do lectures on this, I sometimes refer to big P psychosis and little p psychosis. And what we're looking for in early psychosis programs is this big P psychosis. And the qualities of that is that the psychosis is ego dystonic, meaning it's kind of part of them. Someone who's delusional may believe what they're experiencing is real, yet it's causing a role impairment. So the individual that believes that the government is inserting microchips into their brain, they may believe that to be real and accept it as real, and then they're also not being around electronics or not going to work or not leaving the house because of the fear that more microchips will be inserted into their brain. The qualities of this psychosis are bizarre. Let me define bizarre from a diagnostic standpoint. Bizarre means that it's impossible to happen in the real world. So oftentimes bizarre. Again, these are guidelines. They're not absolutes. So the belief that aliens are inserting microchips into one's brain would be considered a bizarre delusion because it's not possible. However, the belief that a famous person, don't know, Beyonce is in town and Beyonce is in town because she is in love with the individual, although highly unlikely, it's not considered bizarre. And you may have to rule out something like delusional disorder or another condition versus a true psychotic disorder. True psychosis is frequent. It happens daily for hours usually. It's usually described outside of oneself, particularly in the cases of hallucinations, meaning that they experience hallucinations, whether they be visual, more likely to be auditory, but as outside of oneself, sounding like a voice, like my voice sounds to you now, versus an internal voice. And then there's objective findings on your mental status. Things have gotten worse. Emotional expression has changes. Thought processes changes. That's the type of psychosis that is more consistent with true psychotic disorders like schizophrenia versus what I might refer to as small p psychosis, when the individual might experience something that will bother some, but there's less role impairment. So this might be an individual who describes seeing bloody floating heads that only occur at night. It might be bothersome to them, but it's not in a lot of ways getting in the way of their lives. And it's something that may have experienced for some time. Sometimes these experiences are non-bizarre, and that's not bizarre in the clinical way. Somebody is trying to hurt me, for example. Sometimes these symptoms are episodic, maybe only occurring once a day, very brief. They're oftentimes described when you talk to the individuals inside of oneself. Visual hallucinations are much more common in small p psychosis that we see associated with trauma. I just described the floating bloody head, shadowy figures, dark figures, things that people see, oftentimes related to trauma-based disorders and sometimes affective disorders. Not a lot of change on mental status exam, meaning that maybe these are individuals who are struggling, but they've been struggling for some time, and there hasn't been a change. And they're able to talk about it. They're sometimes able to give alternative meaning or value to their experiences. Like, the dark, shadowy figure they may describe as being experienced as similar to a person that has hurt them in the past, whereas someone with a true psychosis may not be able to describe that. The population that you will ultimately be working with in early psychosis programs are young people, most likely adolescents and young adults. So let's kind of just talk about how common psychotic disorders are in some of these populations. In a help-seeking population, so a population that is likely to seek help, but 8% of adolescents will experience psychotic-related conditions or conditions with psychosis, and about 4% of children will. So that's in the help-seeking population. Now, taking that percentage of adolescents and children, so that 12%, that we can break that down to what psychotic conditions they actually had. 41% of that prevalence rate above was due to major depression, 24% to bipolar disorder, another 21% due to some type of depressive disorder, and 14% due to schizophreniform. So 14% of this very small percentage that seeks help who has psychosis is due to the disorders that we ultimately would accept in early psychosis programs, are the ones that we're looking for. So in short, the most common cause of psychotic experiences in children and adolescents are affective in nature versus a true psychotic disorder. How does psychosis ultimately develop? And I'm talking about more true psychosis. This is the work of Barbara Kornblatt. She has a general belief that there's some biological etiology, whether that be genetic, structural, biochemical, functional, some abnormality that exists at a biological level, that over the course of one's life gets triggered in some way, usually around the age of puberty. And this is with schizophrenia. So this is an important differential. If somebody's experiencing their symptoms since the age of 5, you might want to double check that. That's more likely to be more of an affective or trauma-based symptom. someone who's describing their symptoms, who's a 16, 17-year-old, is occurring within the last year or so, now I'm a little more concerned of a true psychotic disorder. Anyways, a progression of these disorders oftentimes start out with some things that we have a really hard time recognizing, like cognitive deficits, inability to, or losing the ability to concentrate, losing the ability to focus at school. It can look a lot like ADHD to many of our referrals to ESAT who had previous diagnoses of ADHD when they were younger. These symptoms ultimately progress to affective symptoms like depression, which actually might be more negative symptoms, but they look a lot like depression. And then what starts to happen is that the individuals receive a lot of social and environmental triggers. Their parents, their schools, their support systems become worried. In some cases, start blaming, like, why aren't you working harder? What's going on? That ultimately can trigger the increasing positive symptoms, which we ultimately recognize as psychosis. Simultaneously, as the positive symptoms are increasing, we see more social isolation than ultimately maybe school or other forms of occupational failure. Where we want, it's very hard to catch individuals in this early cognitive deficit stage, or even in some of these affective symptom, depression, negative symptom stage. Where we want to catch people is right where that red arrow is, where the early positive symptoms are starting to develop before they convert to full psychosis, which is why in our brochures we talk about look for individuals who have concentration problems, who are struggling with social isolation, struggling with hygiene, starting to drop out of school for no explained reason. Those are the type of referrals that we want to get to determine whether they're a good fit for our program. Why do we kind of even talk about the prodrome or this early stage of psychosis? Well, it's important to know that about 90% of individuals with schizophrenia experience this prodromal or psychosis risk stage. So when you're doing your differentials, it's important to evaluate whether a process like this occurred. And then about a third or so of people with a prodromal stage will develop a full kind of psychotic disorder, which then means 2/3 or so will not. So us coming in and mislabeling people as schizophrenia really can do a lot of harm, because it's actually more likely than not that they won't actually go on to develop schizophrenia. What does the schizophrenia prodrome really look like? It's at least one of the following symptoms: delusions, hallucinations, disorganized speech in an attenuated form, meaning that the individual is able to engage in reality testing, but it's still causing problems. It's of a severity level and frequency that it's beyond just normal variation. For example, it's not unusual, nor would we want to pathologize a young person who said they heard their name being called one time or maybe 2 times over the last 6 months. That's not somebody we're going to worry about. Somebody that's hearing their name being called, or starting to hear some voices who's it's happening, at least 4 times a week, starting to get in the way of school, but it still engages in, or still has the ability to engage in reality work, is somebody we would want to screen to see if they'd be a good fit for our program. In this early possible stage of symptoms, which I just described, this prodrome stage, is we don't actually know where the ultimate diagnosis is, so we can't use this tool to say, hey, this person's going to develop schizophrenia, which is actually why they moved away from the term prodrome and actually using the term psychosis risk syndrome. Prodrome is Latin for forerunner, which in some ways implied that if somebody had these early symptoms that they were going to develop schizophrenia, which we now know is not necessarily the case. So these early stages, it might be a psychosis risk syndrome, and that is the syndrome that potentially can convert to schizophrenia. It might be a bipolar risk syndrome, which may later convert to a bipolar disorder, or maybe a depressive syndrome, which might later convert to a more full-blown depressive disorder with psychotic symptoms. The point is that it can go in a lot of different directions early, and what impacts that direction is a wide range of things: environment, treatment. So somebody who has early syndromal symptoms, which might look like early schizophrenia, may ultimately end up with a major depressive disorder, or nothing. So treatment can be helpful, particularly in this early stage, and can curb kind of the end of the railroad, so to speak, kind of which station they land. So here's some of the materials that we use to try to get to make sure that the public is aware and when to refer. So we want the community to know what the early symptoms look like. So here are some of those early symptoms: feeling something's not right, jumbled thoughts, confusions, trouble speaking, being fearful for no good reason, hearing sounds, voices that are not there, declining interest in people, activities, self-care, deteriorating in functioning. Again, we want the public to know what the early signs look like so we can intervene even before someone would have diagnostic criteria of schizophrenia. We have a better shot here. We do this because, as I've already kind of talked about, is psychosis occurs on a spectrum. It's not like you become acutely psychotic overnight. It's kind of occurs usually insidiously and over time. Here are some just examples of psychotic symptoms that you're probably all familiar with: grandiosity, suspiciousness, auditory hallucinations. Somebody at a low level of grandiose symptoms might be someone who really enjoys basketball. Maybe he's an average basketball player his sophomore year of high school, but he expects to attend college on a full scholarship. Now, we might refer to a symptom like that as normal, meaning that the individual is probably potentially overvaluing their skill set. They might be an okay basketball player, but they're probably not going to really go to college on a full scholarship. These are not individuals that we're going to rush into our programs and treat as psychotic or even as psychosis risk. However, we do want to catch an individual before they're headed to New York City because they believe that they're good enough to join the New York Knicks or something like that. That's the true level of psychosis on the grandiosity spectrum. We'd like to catch people somewhere to the right of them, just a little further right of the mean or to the middle. Same thing with suspiciousness. A young woman goes to the mall, feels like people are looking at her. Not them we're going to worry about. Obviously, if she's refusing to go to the mall because there's a certain person that's out there that reads her mind that is going to harm her, that's already psychotic. Again, that would be someone we engage, but certainly we'd want to try to catch her before she reaches that level. Same thing, same idea with auditory hallucinations. Occurs on a spectrum. We want to catch it before it becomes a psychotic level, although obviously we will work with individuals who are at that psychotic level, but we're not going to pathologize those who are at a very, very low level because that could be nothing. So a tool that we help with this, that we use that helps with this, is the SIPS, the Structured Interview of Psychosis Risk Syndrome, developed at Yale. It can diagnose a presence of true psychosis, so it can be helpful in identifying those first break individuals who you would accept. It does diagnose those prodromal or psychosis risk syndromes and measure severity and change, so you can use it as an outcome measure. There's subsets of this tool that you can use to kind of measure how well the treatment is working. It has high levels of inter-rater reliability and predictive validity, and it's been translated into 14 languages. Little caveat on that, that doesn't necessarily mean it's been culturally translated. So culturally, it's still a westernized, developed in the States, it's still a westernized tool, but it has, so culturally translated has not occurred, or cultural translation has not occurred, but language translation has. Here are just some of the questions that we would ask in the SIPS. The SIPS is broken down to different positive symptoms, negative symptoms, general symptoms, disorganized symptoms. Here's some questions under some of the positive symptoms, of unusual thought content. Do familiar people or surroundings ever seem strange or confusing or unreal to you? The response is then ranked on a 0 to 6 scale, and there's some anchor points that help us rank that. We would accept anybody who scores in the 3, 4, or 5, assuming it's happening at a severity and frequency level, there's been a change in the last year, and it's not due to another condition like anxiety, depression, drugs. Some more sample questions. Other signs of psychosis risk syndromes that are not necessarily diagnosable in terms of a psychosis risk syndrome, but are predictors of conversion to psychosis and things we should be paying attention to, particularly if these particular symptoms are also occurring with early psychotic symptoms. So deterioration, things are getting worse. Unexplained decreases in work or school performance, decreased concentration and motivation. If these are occurring also with someone who's having attenuated or lower level psychotic symptoms, these individuals become some of the higher risk of conversion to a true psychotic disorder. Same would be true with social withdrawal, especially when paired with attenuated or lower level psychotic symptoms. Here's that rating scale that I talked about. So each question or each area is rated on a 0 to 6 scale, kind of based on anchoring points throughout the questions. The individuals that we're looking for are people who would score in that 3, 4, or 5 range. We would consider those individuals psychosis risk, and we would bring those individuals into our program. We certainly would also bring individuals who scored the 6. Those are the individuals that are potentially already psychotic, so that means that they are not able to engage in reality testing. And we would bring those individuals in as long as those symptoms had not been present for over a year. Just more examples in the suspiciousness area, just to give, I just want to give you an idea of what the anchoring points look like and how we ultimately score this. So what does a 3 look like? What does a 4 look like? What does a 5 look like? So again, if you're scoring at a 3, 4, 5, something is happening, something is wrong. Doesn't mean it's going to turn into schizophrenia, but something is wrong. So we're not picking up kids who, that the symptoms are questionably present or even mild. Don't worry about them. At least we don't worry about them in terms of developing a major psychotic disorder. So in some ways defending that we're not just picking kids up off the street and labeling them. We're really doing a pretty thorough examination and looking for challenges and really ultimately trying to prevent the onset of a psychotic disorder. Just to give you a more clear idea of the difference between an attenuated symptom and a full psychotic symptom, again, it's all about really, in short, the ability for the individual to engage in reality testing. So let's take a delusion, for example. An attenuated delusion would be this 15-year-old who starts to sit in the back of the class because she has an uncomfortable feeling that other students are whispering about her or laughing at her. She knows this is silly, she knows it's not real, but it just feels better to sit in the back of the class. We may refer to that as an attenuated symptom, and depending on severity and how much level of problems it's causing, she may or may not score on a SIPS tool, as opposed to a delusion where the person clearly believes people are talking about her, reading her mind, making fun of her. She's positive it's happening. In fact, she's so positive that people are reading her mind that she changes her thoughts. She isolates herself at home because of how uncomfortable she is in public. Clearly, you can kind of see the difference there. Same idea with hallucinations. True hallucination, the symptom feels outside of oneself, might be referring to him in the third person, may criticize him. The person believes the voices are real and they're very frightening and they're changing one's behavior. Whereas an attenuated hallucination, these symptoms occur 2, maybe 3 times a week. This person sees colors, wall seems distorted, waves in the wall, hearing some unusual sounds, not happening very often. He's not sure if it's real or not, but thinks it's most likely that his mind is playing tricks on him. Again, an example of an attenuated hallucination. Unfortunately, what I sometimes think happens in our system is that people will experience attenuated symptoms and they get diagnosed with a psychotic disorder, when that's just not, which again is I think a misuse of our diagnostic system, and so they don't meet that severity level to get a true psychotic disorder. And the research now shows that does show that these individuals may or may not actually have a psychotic disorder or even progress to a psychotic disorder. If you are not going to watch this now, if it's kind of given our time, and I want to make sure that we open it up for questions, but do have a video where you can watch Dr. Barbara Walsh. She is one of the authors of the SIPs. You can, if you want to cut and paste this or whatever, you can watch her describe the SIPs, and she gives a brief example of an interview she does with somebody. So you can get kind of a 4-minute kind of clip of what completing the SIPs looks like. This is on our YouTube channel. We have this video amongst various other videos that you can watch kind of that will describe some of the work that we do in our program, interview with participants that have bravely put themselves out there to describe their stories, are all available on our YouTube channel. Okay, I think what I'm going to do now is open it up for questions and anything else that we can do for you today. So I don't know, Jenny, if you want to unmute or if you prefer to take chat questions, either way is fine with me.
I thought it was a great demonstration. It just really kind of enhanced maybe stuff that we already know, but to make us more vigilant to watch the people in our community and hopefully be on that prevention end of things.
Tamara, are you muted?
I'm now unmuted.
Okay.
Sorry. So yeah, thank you for that feedback. And I think one of the things we also were thinking about, is that there are a lot of things that we can do today. So what you were talking about around just being a little bit more aware, and early on when we were talking about duration of untreated psychosis and the causes of that, we tried to kind of put out some ideas of things that you could potentially do today in your organizations that wouldn't actually require new resources necessarily. So are there any other thoughts or questions?
Yeah, I think we have Scott Wilcox on the call, and he is asking, can you talk a bit more about how to rule out medical issues? What tests? CT ?
Yeah, we have a series of tests that we recommend, and those are listed in our practice guidelines. But yes, certainly CTs, MRIs if indicated.
Yeah, I think most of our medical folks don't usually routinely pursue the CT or MRI, although there could be some debate about when that should be done. They primarily do that if they see other kinds of medical signs like headaches or things that might suggest some kind of a brain tumor or head injury.
Yeah, standard lab, CBC, thyroid, those type of basically kind of standard medical tests. Any finding may result in further evaluation. At least to start with, and then from there, obviously, move on.
And we can send you the link to where you can find that list.
Does anybody else have any questions while we're looking for that information or comments, feedback? There is a really short survey that gets sent out automatically after the webinar finishes, and it would be awesome if you could all please take a look at that. We are trying to tailor these webinars to what your needs are, as well as being able to provide information, tailor anything to you.
Okay, so I'm going to post in the chat box the link to our practice guidelines, but they are at isacommunity.org, and if you look in the For Providers section, you can find the guidelines. It's on page 10, is the list of the recommended medical tests. Do people have any thoughts on things that that you could be doing today in your organization that would be kind of low-hanging fruit? I'm just curious.
This is Patty at Solutions for Life in Douglas, and I teach QPR, and what I've noticed when I go out and teach some of the community about suicide prevention, it's basic information. It's not, they don't have to have a therapy degree to understand it, but it just makes them aware of the people around them and some of the signs and the symptoms. And I think it's really opened up a conversation in our community and made people kind of break that stigma down. And so I think if there was a similar, about early signs of the psychotic training that, was short, so you didn't take up too much of people's time, but at least gave them a few guidelines just to the general public. I think it would really help break the stigma and open up communication about just talking about mental illness and who's out there to help. So.
Yeah, that's great, and that might be something we could actually support you in. I know that the state of Washington actually just recently added a psychosis piece to their QPR modules, so they might be willing to share that with you. And of course, there's also some really great just written material for the general public, and we'd be happy to share with you what we use.
Those are located on our website. At least one of our brochures is that has some of those early signs in pretty simple language at isacommunity.org.
Yeah.
Okay, I will definitely get some of those. Thank you.
Any other thoughts before we head out? We just encourage people to go to our Facebook site, So.
And our contact info. But anyways, yeah, that's all available at eastcommunity.org also.
Okay.
Follow us on Facebook, follow us on Twitter, watch us on YouTube. All those links are there, and if this gets sent out, then you can use those resources. Or you can use
awesome.
your cell phone and use the QR scanner right there and go directly to our website right now.
Yeah. And one of the things that we're doing right now is we have we're in the process of putting together a national learning collaborative. And we're putting together a toolkit that will be housed on the website that will have things like, community education materials or, examples of policies and procedures that different organizations have put together. So it'll be a place to share a lot of this kind of information. So there's a lot of good stuff out there. So feel free, if you guys have any questions that come out at a local level, where you're looking for particular kinds of resources, to send us an email and we'll try to connect you up with the specific things that you're looking for. So on the next call, we'll be talking about some of the specific practices involved in early psychosis intervention that are really kind of core elements, and we'll try to tailor it to what you can do with limited resources in a rural area, as well as talking about kind of what the optimal level is. So we'll look forward to having that conversation with you all, and again, feel free to reach out in between calls. And it sounds like we don't have any more questions, so we probably should call it a day and wish everybody a happy weekend.
Thank you so much, Tamara and Ryan. That was a really awesome presentation, and looking forward to webinar number 3, which is happening next Thursday at 9 o'clock. Please do join us for that and get in touch before if you have questions or suggestions. And thank you so much for joining us today.
Thanks, everybody.
Thank you.